Good evening, everyone. Welcome to the Regional Anesthesia Workshop, Motor Sparing Blocks for the Lower Limbs. This event is organized by the Society of Anaesthetists of Hong Kong, supported by the Regional Anesthesia Special Interest Group, and sponsored by Prof. I'm Dr. Vivian Zheng, Associate Consultant from PYNEH and the Chairlady of Regional Anesthesia Special Interest Group. I'm honored to be your moderator tonight. Regional Anesthesia Special Interest Group was newly set up this year, aiming to promote the exchange of knowledge and skills of regional anesthesia. As the first event of our Special Interest Group, we are privileged to have Professor Paul Kessler from Germany. Our night will begin with lectures and ultrasound demonstration by Professor, which will be recorded and be available for revisiting after the event. It will then be followed by hands-on experience in small groups. Before the beginning of the event, may I first invite Dr. Chi, the Chairlady of Society of Anaesthetists of Hong Kong, to give us a welcoming speech. Thank you.
Thank you, Vivian. Well, first of all, again, good evening, ladies and gentlemen. So happy to see many familiar faces tonight. Warmest welcome again to this Regional Anesthesia Workshop, which is co-organized by SAHK and also the Regional Anesthesia Special Interest Group. I think tonight is very meaningful in the sense that this is the very first collaborations between SAHK and a special interest group by our young people to organize an academic event. I mean, we did face some logistical challenges, but then with a very strong determination by all the young members in the group and their great effort, we sort out everything and we're here tonight. So I think you should give yourself a round of applause for all the great work that you've done tonight. And we're very honored to have esteemed guest, Professor Kessler, with us tonight, and also quite a few very talented local experts. So we have Fiona, we have Ara, we have Bufai, we have Eddie tonight with us. So I think this is going to be a very meaningful and rewarding evening. So before I hand over the stage back to Vivian, I would like to extend our heartfelt gratitude to Prof for their very generous support, without which this is not possible, the event is not possible. And also special thanks again to Vivian and the Regional Anesthesia Special Group. I think your passions and your perseverance is just amazing and you should keep that up. So thank you everyone and enjoy the evening.
Thank you, Dr. Chi. May I now introduce our guest speaker, Professor Paul Kessler. Professor Kessler is board certified in anesthesiology, critical care medicine, pain therapy, and emergency medicine, and was awarded professorship in anesthesia in 1998. He was the chair of the Department of Anesthesiology, Intensive Care Medicine, and Pain Medicine of the Orthopedic University Clinic in Frankfurt, Germany. He was also the vice chairman and became the lead consultant of the Clinic of Anesthesiology, Intensive Care Medicine, and Pain Therapy of the University Hospital Frankfurt in 2020. His clinical expertise focuses on regional anesthesia. Professor Kessler has co-authored over 100 peer-reviewed papers, reviewed articles, case reports, and book chapters. Professor Kessler is a member of many national and international societies of anesthesia. He was the chairman of the German Task Force of Regional Anesthesia, board member of the ESRA, and the German zone representative of the ESRA Council. Since 2016, he has been the chair of the ESRA Cadaver workshops. Professor Kessler will deliver captivating dinner lectures titled Peripheral Nerve Block for Lower Extremities, Applied Anatomy and Sacral Plexus Nerve Block, and Hip Fractures and Regional Anesthesia, an exact technique for hip fractures. Without further ado, let's welcome Professor Kessler.
Thank you very much, first of all, for the nice introduction here, and thank you also for the SAHK and the Prof company for organizing this workshop here, and it's a great pleasure for me to be here and to give you some lectures and also some demonstrations in the nerve blocks. So I was asked to give 2 lectures. First of all, one of the PNBs for lower extremity blocks and the blind anatomy of sacral plexus nerve block, especially the IPAC block. And the second one is dealing with a hip fracture. So let's start with the first one. Are the topics I'm going to talk about. You should now start with dinner. Don't forget the dinner. Maybe it's much more important than my presentations. So I'm going to talk about lumbar plexus, sacral plexus, and for example, PNBs for major knee and ankle surgery. This is my conflict of interest. I got honoraria from different companies, and also I'm in the advisory board, but this will not influence my presentation of today. So I think only 2 or 3 slides about the anatomy. You know, the lower extremity is in there are 2 plexus which are important: the sacral plexus for the backside and the lumbar plexus from T1, from T12, L1 to L4 for the anterior side. The sensory innervation is very important before we do a block, because we want to have, after the operation, a block which covers the area of the operation. But by doing this, not only the sensory innervation is important, but also the myotomes and the sclerotomes are very important to know. I think usually you are familiar with this. You know, the quadriceps muscle is the most important muscle for the lower extremities, innervated by the femoral nerve, and the back part here is innervated by the biggest nerve. This is the sciatic nerve. And this is a statement of an orthopedist, and he stated that the use of peripheral nerve block in lower extremity surgery is becoming a mainstay of perioperative pain management. As long as I was head in the orthopedic university, nearly every patient has got a peripheral nerve block, and if not, the anesthesiologist has to justify why the patient didn't receive a nerve block. We know that regional anesthesia doesn't stand alone. Regional anesthesia should always be part of a multimodal analgesia concept. And if we look now for the innervation of the knee, you see the front part of the knee. For the front part of the knee, we can do a lot of blocks. We started many years ago with the lumbar epidural, lumbar plexus from proximal to distal, fascia iliaca, femoral nerve, femoral triangular ductal canal, genicular nerve blocks, or the local infiltration technique. And for the posterior part, we can block the sciatic nerve. We can block the sciatic and the whole length, but 2 or 3 areas are prominent. These are the proximal sciatic blocks over here, and the distal sciatic block, or the popliteal blocks over here, and also the IPAC. And we can do also for ankle blocks. My last slide in this presentation are dealing with the ankle blocks. If we look now at the literature, there's a question: what are the best blocks for major knee surgery? For example, total knee arthroplasty. And you can see here a meta-analysis including 170 papers, and they found out that the best combination for pain relief, these are the 5 addressed, the best combination is a femoral nerve block and sciatic nerve block for pain relief, only pain relief. But we know nowadays our orthopedist and traumatologist wanted the patient to be mobilized very early after the operation. As a consequence, we can no longer look only at pain relief when we do a block. We should also allow with our blocks that the patient can be mobilized very early. That means pain relief and mobilization. And based on that, and this is also forced by the so-called ERAS concept, enhanced recovery after surgery. And this is the Danish surgeon Henrik Helek who first propagated ERAS. ERAS was first introduced for colonic surgeries, but now we have ERAS principles for any kind of surgeries. That means the patient should be mobilized early and sent home very early. And regarding the ERAS concept in orthopedics and traumatology means early mobilization and early start with rehabilitation. And again, we have all other issues which are important. For example, if patients undergoing major knee surgery, This means for the joint function, we should also prevent falls. Also, we should follow the concept of opioid-free or less opioid-sparing analgesia. You know, opioid abuse is a huge problem in the United States. Nearly between 100 and 200 people died every day on an overdose on opioids. This opioid abuse started in the 90s when oxycodone was prescribed, and the prescription policy in the United States is one of the reasons why they have an opioid crisis. But I think there is no other country worldwide which has such an amount of opioid crisis as in the United States. Nevertheless, to reduce the amount of opioids, it's also something that should follow in older people, because we know about the opioid side effects. And patient satisfaction is also very often combined with anesthesia, because if you give a high amount of opioids, you see a high amount of opioid side effects, such as nausea, vomiting, and so on. So based on this also, we should move, when patients undergoing major knee surgery, we should move from proximal blocks to more distal blocks. And the more distal we do our block, the less muscle weakness, that means the less quadriceps weakness we can find. And you can see here the innervation of the knee, and you see mainly is innervated on the anterior part from joints or from branches of the femoral nerve, and from the posterior part mainly by parts of the tibial nerve, but also of the obturator nerve. And motor sparing blocks, this is what we are following now to realize an early mobilization of the patient. That means we should do the blocks close to the joint. This not only applies to the knee joint, but also applies to the hip joint. I come to this in my second talk. And based on this, to give a good analgesia and allow an early mobilization, these are the candidates we should now follow when patients undergoing major knee surgeries. A femoral triangle block, adductor canal block, or these for the anterior part, and for the posterior part, we should do a popliteal plexus on IPEC block. So, which are candidates? For example, adductor canal block and femoral triangle block. I hope you are familiar with these blocks. Nevertheless, we can also demonstrate these blocks. You can see here, this is the ultrasound picture you're looking for. You look for the femoral artery, you look for the sartorius muscle, and then you advance the needle from lateral and places the tip close to the femoral artery, where you can find the saphenous nerve, which can be blocked then. The difference, the performance of an adductor canal and a femoral triangle block are nearly the same. The difference is only when you do a femoral triangle block, you place the probe a little bit more proximal, and if you do a adductor canal block, you place the probe a little bit closer to the knee. But only with the ultrasound you can identify where the adductor canal starts and where the adductor canal ends, and when you find the place where the adductor canal starts and you place your probe a little bit more proximally, then you can perform a distal triangle block. If you move the probe a little bit more distally, then you can perform an adductor canal block. You see here an anatomical preparation. Left side is caudal, right side is cranial. This here is the adductor canal, this is the vasoadductor membrane, and you can see here the saphenous nerve going into the adductor canal. But why I show you this picture is because you see the nerve to vastus medialis here, and he's not going into the adductor canal a little bit more proximal, he has his own canal. But this is a very important nerve for the analgesia of the knee. So if you do a classical adductor canal block, usually you will not have blocked the nerve to vastus medialis. The nerve to vastus medialis, what will you have blocked if you do a distal femoral triangle block? Therefore, in our department, when we have a major knee surgery, we always do a distal femoral triangle block. If we have minor knee surgeries, then we do an adductor canal block. So the other option for the other block option, which also gives a very good analgesia and allows an early mobilization after major knee surgery, is the local infiltration analgesia, which is routinely usually done by the surgeon. There are different techniques how you should do it, and you see here a meta-analysis comparing the local infiltration technique with a single shot peripheral nerve block, mainly a femoral nerve block, and they found that the LIA, the analgesia with the LIA is not inferior to the peripheral nerve blocks, and mobilization is better, but only in the very first post-operative hours. Indeed, when your surgeon has done a very effective LIA, the patients can be mobilized immediately post-operatively, or he can stand up and without any pain. Another option are the genicular nerve blocks. Some called it is the LIA by the anesthesiologist. You know here the genicular nerves, there are different nerves, supramedial, this is supramedial, this is inferior medial, and supralateral. You should never do the inferior lateral, because then you are very close to the peroneal nerve. But if you're blocking these, if you do 3 blocks like this one in combination with the block of the nerve to vastus intermedius, then you have also a LIA similar block for the knee, and the patient should also be pain-free or should have less pain and can be mobilized. The question is always among anesthesiologists, is a block of the anterior part of the knee sufficient for pain relief, or should we add also a block from the posterior part? That means, should we also block the sciatic nerve? I think the most important part is the anterior part of the knee, but if you block the posterior part, the patient probably feels better. And when we postulate a near joint block for the posterior part, which allows mobilization, so we should do an IPEC block. IPEC is, the abbreviation is infiltration between the popliteal artery and the capsula of the knee. You see here, this is the medial approach we show you later on, and this is the popliteal artery, and you see the infiltration is between the popliteal artery, and this here is the femur. The details I show you later on, and you will be demonstrated this, and you can also scan on the models later on. And indeed, there are many studies showing, comparing pure adductor canal, for example, with a combination of adductor canal and IPEC with patients undergoing knee replacements. And if you do a combination from anterior and posterior, then you have a better pain relief compared to block only from the anterior side. And also mobilization will be improved because one prerequisite for good mobilization is that the patient is pain-free. So you can see here now a little bit more details about the IPEC. We know from very old anatomical study, you can see here 1984, the posterior part of the knee is innervated by the so-called popliteal plexus, mainly from fibers of the tibial nerve, but also of the fibula and obturator nerve. And you can see here again an anatomical preparation. This is caudal, this is cranial. You see here the sciatic nerve and the 2 branches, the tibial nerve and the common peroneal nerve. And you can see here at the level of the popliteal crease, you see this plexus, and this is the popliteal plexus, and this is the target for an IPEC block. This is the technique I showed you before, and this was also the first technique when this block was described by Sina from the United States. You see here, you advance the needle between the femur and the popliteal artery here close to the femur. Before you do this block, you can always, as usual in all blocks, you can use the color function to identify the vessels to avoid a vessel puncture, and the needle is then When you have done this, the needle is advanced from here to here. Now you can see a picture here. You can see the needle is coming from here. The needle tip should be placed below the artery, and then under retraction, slowly retraction, you started infiltration with 20 to 30 ml of local anesthetics until you are here and at the end of the femur. So this is the area you will infiltrate with your local anesthetics. The only thing you have to look for is, or two things: you should not puncture the popliteal artery and you should not hit the tibial nerve. That's why you should always do the block, the IPAC block, from medial to lateral, not from lateral to medial. My preferred technique today is this one. You see, I place the probe. This is the so-called posterior approach. I place the probe in the popliteal crease, and then I, with the same effect, I advance the needle from medial to lateral. You see that the leg is outer rotated. This is the right leg. Patient is in the supine position. The leg is outer rotated, flexed in the knee. You place your probe over here, and then again there are two approaches. You see here at the level of the medial and lateral condyle. This is the so-called distal approach. And then when you move the probe a little bit more proximally, then you can see only the femur. And this is medially. This is lateral. You see here the popliteal vessels. Here the tibial nerve, and then the needle is advanced over here. I think you see here again the condyle, the medial condyle. The needle is coming over here. This is the artery, and when you are with the needle here, you start to inject under retraction of the needle. You can see here under infiltration, the needle is retracted over here. By the way, it's postulated that this is a block which allows early mobilization, but you can see over here, if you inject a huge amount of local anesthetics over here, it's possible that you can block secondly the tibial nerve over here by the local anesthetic. So in some patients you can find also an impairment of mobilization, but this is related to this fact that the local anesthetics from here is also blocking a little bit the tibial nerve. So another question is, should we use for major knee surgery a single shot, or should we use catheters? And if we go back to all these options that we have, you can see we can place catheters if we do a femoral triangle block, a ductal canal block, or even the surgeon can place a catheter during the local infiltration analgesia. And there are a lot of papers, and I show you only two or three. First of all, you can see here an older publication showing if you compare peripheral nerve blocks overall with single shots, you can find with peripheral nerve blocks a superior analgesia in the postoperative period, especially in very painful procedures. And usually all major joint operations are very painful because it's now advocated that the patient should be mobilized immediately after the operation. And every mobilization hurts. You see here a single shot versus continuous femoral nerve block, and with a continuous femoral nerve block you have better pain relief and reduced opioid consumption postoperatively. If you see here continuous adductor canal block with a single adductor canal block, you see with a adductor canal catheter you have a better postoperative pain relief after 24 or 40 hours, and a larger range of motion that has the mobilization is better preserved under an adductor canal catheter. And here these are recommendations from the American and European Society of Regional Anesthesia how to perform total knee arthroplasty. The preferred technique should be the spinal anesthesia, and you should always consider peripheral nerve blocks, single injection or continuous infusion, or the surgeon should do a local infiltration analgesia. So how we do it in our hospital, total knee replacement, we place a femoral triangle catheter, we do a proximal, sometimes a proximal or an IPAC block in addition. Intraoperatively, we give a general or a spinal anesthesia, depends on the wish of the patients, for example, and many of our surgeons don't want to have a spinal because they've talked too much. They can, if the patient has a spinal, they must be a little bit scared what they are saying and what they are doing, and they like it more, or many of the surgeons like it more if the patient have a general anesthesia, so it's easier for them to do the operation. So the femoral triangle catheter we used for 2 or 3 days, and every catheter in our hospital is connected to a PCR pump. You see, we always use ropivacaine, 0.2% for postoperative analgesia, and this is the settle how the pump is started. 3 ml bolus every hour, and lockout time. A continuous infusion with 3 ml per hour and a bolus of 5 ml every hour, and a lockout time of 1 hour. So this is the latest publication regarding recommendations for ambulatory total arthroplasty. You know, even in the meantime, in the United States and also in some other countries, but mainly in the United States, major knee surgery in uncompromised patients or in healthy patients are in the meantime a day case surgery. So they recommend for anesthesia continuous IPAC block for with LIA on IPAC, and you can see here these are 3 different cities in France. This doesn't matter, but you can see here 3 hospitals and 3 different kind of analgesia techniques for major knee surgery, and all these patients are mobilized the same day. In this patient has only a LIA. This patient had a LIA with a continuous adductor canal, adductor canal catheter, and this had only a continuous femoral block. But all these patients could be mobilized the same day. What I will say with this pictures that show you should use the technique you are familiar with, and you can see you can eat with different techniques, you can reach the same goal. That means good anesthesia and mobilization of the patient. Many ways are lead to Rome. Oh, I'm not finished yet, but you see what factors do we have which influence our procedure, for example, after major knee surgery. It depends on what kind of patient we have. If we have an opioid tolerant or opioid dependent patient, or a patient with chronic pain, in these patients we prefer a catheter technique because we want to avoid in these patients opioid in any case. So we use the femoral triangle catheter or adductor canal catheter. When the early mobilization is required, but we've seen a lot of older patients with severe knee pain over weeks or over months, and you can find in many patients quadriceps weakness already before the operation. You see here, these are MRIs, and you see the muscle, the quadriceps, the quadriceps muscle is much more lower in this in the patient on the side which should be operated, and it's not surprisingly that after the operation these patients will have problems when they should be mobilized. But this is not a problem of anesthesia or catheter. This is a problem of muscle weakness starting already preoperatively. Also, it depends on what kind of block you prefer, depends on the anesthesiologist. When you are not familiar with some kinds of blocks, you should use the blocks you are familiar with. It also depends on some surrounding conditions. You should use catheters only if you have an acute pain service. If you use catheter in a patient, you need special staff which is looking after these patients at least twice a day, and also to adapt the infusion pump or the PCR pumps to the need of the patient. Sometimes you have to increase, sometimes you have to decrease the infusion rate, and overall with longer last from day 0 to day 2, you have continuously to reduce the amount of local anesthetics in the patient. and also the techniques and the equipment. If you have no ultrasound, you cannot use, for example, an IPAC, and you cannot use, for example, a pen block. And also the health policy and reimbursement policy is a problem. For example, in Germany, Germany is one of the countries with the highest rate of beds per population, and the Medicare reimbursement, the full Medicare reimbursement, you will only get if the patient stays at least 2 days in a hospital. And if you send the patients home earlier, the hospital will lose money. That means this only makes sense for the hospital if you have a long waiting list, and if you send the patients home after 1 day and you know this bed can be filled with a new patient, then you can increase the amount. And finally, I will come to the ankle blocks. Ankle blocks are also very useful blocks for distal, for foot surgeries, for example. We have different kind of ankle blocks. We have 2 deep and 3 superficial blocks. The peroneal and the tibial block are the deep blocks, and here all the blocks starting with S in the name are superficial blocks, and the most important ones are the deeper blocks here, the tibial and the deep peroneal nerve blocks. And the question is a saphenous nerve block, for example, necessary if you do a hallux valgus surgery? Only in 3% this area is innervated by the saphenous nerve. So usually if you do a hallux valgus operation, you don't need, in addition to a popliteal nerve block, you don't need to do an additional saphenous nerve block. But for major ankle surgery, you should always do an additional saphenous nerve blocks if you want to do this operation without general anesthesia. And here's some recommendations. If you do ankle surgery, a hind foot surgery, or forefoot surgery, the kind of block depends on also of the tourniquet. If you do a thigh tourniquet, leg tourniquet, or ankle tourniquet, as you can see here, ankle tourniquet does not harm the patient. You can use it without any additional efforts. If you need a thigh tourniquet, you should do a proximal sciatic block and a femoral nerve block. If you use a leg tourniquet, a popliteal block is sufficient, plus saphenous nerve block. And if you use an ankle block for distal procedures, you only had to do ankle blocks. And here for hallux valgus repair, these are recommendations from an expert group, the ProSpec group. The procedure specific recommendations, and they recommend ankle block is recommended as the first option for hallux valgus repair surgery. And you can see here again a video. This after hallux valgus operation, and this patient had a popliteal block, and it's difficult for her after the operation to stand up and to walk alone with a distal popliteal block. But if you have done only an ankle block, you can see after the same surgery, it's easily for the patient to walk with this ankle block. This should also tell you it depends on the kind of operation, if you do an ankle, foot, hind foot, or forefoot surgery, and the use of blocks, if the patients can be mobilized very early or not. And this was my last slide. Thank you very much. So now we move quickly to the next, we want to move to the next presentations, and this is hip fracture and regional anesthesia, especially focused on the pen block. Again, you saw this is my agenda. Okay, you know, hip surgery is one of the most popular operations in older patients. You can see here the old Queen Mum. She got a hip replacement with 95 and survived. And this is the oldest one of the UK, 112, and also she got a hip replacement. And you see here some data about epidemiology. 1.6 million hip surgeries worldwide, second leading cause of hospitalization in the earlier, but 1/3 of the patients is unable to walk after independently, and only 20% to 75%, or 20 to 75 do not regain pre-fall walking ability, and you see here 25% do die after 1 year.
When we talk about hip surgery, you have to keep in mind hip surgery is not hip surgery. It depends on if you have a transcervical hip fracture, if you have a subtrochanteric hip fracture, and so on. There are many different types, and also the many different types require different kind of operations. You can see here the most common is the petrochanteric hip fracture, but we also see some, and these are difficult cases, periprosthetic hip fractures. Mostly the patient, the femur is fractured over here, and these are long-lasting and very huge operations with a huge blood loss intraoperatively. Another question is also which outcome we are looking for when we do a block, or what are important outcomes for the patient. Is this mortality or morbidity? In the last years, more important has become patient-centered outcome. That means quality of life after the operation. When can he start, or when can he return to his normal life, or when can he turn to start working in his job? Or you see here pain quality or pain intensity is also an issue, and you can see here these so-called weak outcome parameters are more and more important in the last years, but these are, I think, the outcomes, mortality or post-operative morbidity, which are mainly looked for in studies. And these are a set of a core outcome set, which a group of UK found out. These are outcome parameters we should look for in the future when we look in patients at patients undergoing hip surgery. And there's also a difference between patients undergoing an elective hip replacement, or if we get a hip replacement due to hip fracture. The hip fracture patients, these are emergencies, they are unprepared, they are older, they have impaired coagulation. Many of these older patients are anticoagulated, and they have a lower HB. And you can also see the mortality is different between hip fracture, much more higher compared to elective hip replacements. And you can see the hip mortality of hip fractures is about 35% after 1 year. And there is also the increased mortality after hip fracture operations depends also on the comorbidities the patient has. And we know that older patient has a lot of comorbidities, and if you are older than 70s, usually you can have 5 comorbidities or more. And we know also that the comorbidities are an important factor regarding the perioperative risk, especially in older patients. In younger patients, especially in babies, it's the surgery and the anesthesia which is the main risk, but in older patients it's other comorbidities. And as a result of that, you can see here the number, the cumulative morbidity. You see the mortality rate, and you see here the comorbidities. And if you have 3 comorbidities, you have a significant higher mortality compared to those patients who has only 1 or 2 comorbidities. Frailty is also an important factor regarding length of stay in hospital, but also regarding in hospital complications or staying in the hospitals. So many of the older patients are frailty, and before we do the operation, we should always check. We should use a frailty score. This is sometimes what we not yet routinely use in our hospital, but if it helps post-operatively to explain why some patients have to stay longer in the hospital or not. Also, the outcome depends on the kind of operation. You can do after a hip fracture a major operation such as a hip arthroplasty, or you can do a minimal invasive operation such as leg screw osteocentesis. And the kind of procedure depends again on the clinical situation of the patient. If you have a very sick old patient, you will do maybe a minor operation with not a huge amount of blood loss, with shorter duration. And in a patient with a very good condition, you can do maybe a total hip arthroplasty. And also for hip surgery, is relevant. One when will you do the operation? And we all know if you do an early operation, earlier than 48 hours, here you can see these are data from UK, you have a reduced 30 days and 1 year mortality. In Germany, the recommendation of our Society of Surgeons is to do the operation within 24 hours, unless what kind of comorbidity the patient has. But the earlier to do the operation, the better is the outcome. But influencing factors, the outcomes, the patient's characteristic, I mentioned this, it also depends on what kind of anesthesia, what kind of block I do, and also what kind of study design I have chosen, if I have do a prospective randomized trial, or if I look at meta-analysis and big data. For example, the question is among anesthesiologists always, which is the best anesthesia technique for hip surgery, regional anesthesia or spinal anesthesia or general anesthesia? And we have two big randomized controlled trials. One of these in the last years, one of these is the Reagan trial, and they included 1,600 patients, and they found regarding death after 16 days no difference between general anesthesia and spinal anesthesia, and the difference is only 0.2%, but this is not significantly. And also a follow-up just published this year, looking after 1 year, if there is a difference, there is no difference regarding death and inability to walk between patients receiving a spinal or receiving a general anesthesia. On the other hand, if you look at big data and retrospective data, this here is an expert group, and they included 94 studies, 100,000 of patients, but also retrospective analysis, and they found for new axial, that means mainly spinal anesthesia, a lower mortality rate and lower complications for several organs, pulmonary complications, renal failure and so on, less rate of thrombosis and so on. And they recommended that for hip arthroplasty, based on the current evidence, neuraxial anesthesia should be preferred. So what should we do now? Should we now offer the patients a spinal anesthesia, or should we offer a general anesthesia? My question to the audience, which one is using a spinal for hip? Please raise your hand. Which one is using a general anesthesia? I think the majority is using a spinal anesthesia. And I think you are right. Because you can see here, the problem is, you can see here on the y-axis the number of patients, here the expected difference. If you do a randomized controlled study, you made you made always a statistical analysis, how many patients should are involved in this study. And if the expected difference between the two groups you compare is high, for example, around 10%, then you only need a small number of patients. But if the difference is low, and if you remember the difference was 0.2%, that means if you would do a randomized controlled trial showing that the spinal anesthesia would be better, you need more than 10,000, maybe 20 to 30,000 patients. Then you would also could demonstrate in a randomized controlled trial that the spinal anesthesia is better. But as long, not now, but also in the future, this study will never be done because it's impossible to include so many patients in a randomized controlled trial. So we only have the retrospective study data, and I think the retrospective study data are right, and indeed spinal anesthesia is better. So what about some things such as postoperative delirium? Is there a difference between spinal and general? And you can see here, if you compare spinal with general anesthesia, there's no difference. What you also can do here, these are data from a German hospital. They used, it is in German, but they used a case series of 7 patients. You can see very old patients. They all were anticoagulated with DOACs or fenbrocumon and so on. And what they did for these, for hip surgery, they did a high sacral plexus block, a psoas compartment block, an anterior quadratus lumborum block. And under these 3 blocks, the patients can undergo a hip surgery. And these are all patients not suitable for general anesthesia and also not suitable for spinal anesthesia. So what kind of post-operative analgesia should we use after hip surgery? You can see here why a spinal anesthesia is better. You see the scores, the VAS scores, and use the time. If you do a spinal, you have for 4-6 hours post-operatively, you have no pain, you have lower pain scores compared to a general anesthesia after hip arthroplasty. And if you see here patients with severe pain and with mild or moderate mild pain, you can see if patients have severe pain, they have a longer stay, ambulation takes longer, and also the delirium rate is higher if the patients have severe pain because you need more amount of opioids. So when patients undergoing hip fracture surgery, we could use post-operative a kind of multimodal analgesia. We should have tried to avoid opioids, and we should focus on regional and local techniques. Here, a meta-analysis, a systemic review, pain management after hip, and you can see here femoral nerve block, psoas block, combined blocks, or 3-in-1 block, epidural and fascia iliaca block. All these studies showed they reduced pain, and this is a strongly recommendation to reduce the incidence of delirium when you use for post-operative pain relief any kind of block. Another study here, you see the different nerve blocks here, femoral, fascia iliaca, obturator, psoas block. All of them, they all are able to reduce the, I think this was, they are all able to reduce the pain compared to an IV technique with opioids. And again, these expert groups, I show you the data before regarding this comparing spinal and general anesthesia for hip, and these are now, if you use peripheral nerve blocks or IV opioids for post-operative analgesia, patients undergoing major hip and knee surgery, and you can see here again more than 1 million patients, and you can see here in green, this means a high evidence, and blue, a moderate evidence. You can see the delirium rate is lower, post-pulmonary complications, gastrointestinal infections, surgical site infections, transfusions rate, and deep thrombosis. These are all data showing that it's better if you have patients when patients will receive peripheral nerve blocks for post-operative pain therapy. And also, if you see here, post-operative delirium rate is lower when you use post-operative regional anesthesia, and not only for hip surgeries, but also for all surgeries. And if you use, for example, truncal blocks for other surgeries, you can reduce the amount of delirium when you use these kind of blocks. So the pain management is very important to reduce the deliriums. If you can reduce opioids and increase regional anesthesia, there is a good chance to reduce the post-operative delirium. And this is an interesting study. I show you this only because they looked at the duration of surgery and post-operative delirium, and have found every 30 minutes increase in duration of surgery was associated with an increase in delirium rate. This is something we should tell our surgeons. Please do the operation fast, and then we can reduce the amount of delirium in our patients. We also have other blocks, for example, for hip surgery, PENG block, erectospinal plane block, or quadratus lumborum block. You see here the PENG block, first described for hip fracture in 2018. Again, this hip PENG block means you pericapsular nerve group block. You will block the nerves close to the hip surgery. This means the femoral nerve, the obturator nerve, accessory obturator nerve. And one point, regard the name. You know, the first describer of this block was Philip Peng from Canada, but he always refused to accept that the name Peng was named after his surname. He said, no, this is a coincidence, but everybody is convinced that he tried to find a name which is the same as his surname, and then he named the block after his surname. Okay, nevertheless, This is an opioid-sparing block, of course. We will show you how we do it later on. Again, this is what you are looking for. I will not go into much detail because we will demonstrate it now. This is an easy block you can do before the surgery, and this is a block we always do after we had done the general anesthesia or after we had done the spinal. Then it's absolute pain-free for the patients. And there are a lot of publications showing that PENG block is effective, and this is a standard block in our hospital for elective hip surgeries and for patients undergoing hip after hip fracture. You can see here 15 to 20 ml of local anesthetics. You can even use a higher concentrated of local anesthetics because you don't will find impair of mobilization. The lumbar erector spine block is another block. You can see here patients in the lateral position, and also with this lumbar erector spine block you can block the nerves of the lumbar plexus. You can see it is done here. It is not so popular, but as you do the block from the back side, you are far away from the incision side for the hip surgery. You can also place catheter here for this block, and the operation can be done safely. And finally, we have different quadratus lumborum blocks, and this is the transmuscular or the anterior quadratus lumborum block. This is a block also very effective for hip surgery, but this is also a second line block when we don't want to, or when we cannot make, for example, a PENG block because the surgeons don't want to do the block because it's too close to the surgical incisions. Here you can see again recommendation from these expert groups. Regional anesthesia, single shot femoral nerve block, for example, should be done. And you see here a summary of all the blocks you can do for hip surgery: suprainguinal fascia iliaca, psoas, quadratus lumborum, lumbar erector, PENG and LIA block. And which block you prefer, again, depends on what outcome parameter you are looking for. If the desired outcome, early ambulation or opioid-free, if you have a patient with high comorbidities or chronic pain patients or an opioid-dependent, if you are familiar with all the blocks, and if you have limited resources and not acute pain service, and for example, if the desired outcome is early ambulation or opioid-free, you should do a PENG block, and also to a minor extent you can also do a suprainguinal fascia plane block. If you have a very painful patient with high comorbidities or chronic pain patient, you can also do a PENG block or suprainguinal block. If you have a patient with high comorbidities or opioid-dependent patients and you want to avoid any kind of opioids postoperatively, you can do again suprainguinal, quadratus lumborum, erector spinae, and you can place catheters for quadratus lumborum or lumbar erector spinal. And if you have pain service, then again you can use this. You can also place fascia iliaca block. You cannot use a PENG as a maybe you can post-operatively you can place a PENG catheter. There are also some places. And finally, again, these latest publications. What about ambulatory total hip arthroplasty? This is very common in the United States. Anesthesia, you should give a spinal anesthesia, or you can give a general anesthesia. And for post-operative analgesia, you should consider a PENG block, but you have seen there are many other blocks you can also use. So I summarize: hip fracture, preoperative, prefer analgesia, peripheral nerve blocks over opioids. You should do the block within 24 hours. Probably you have to optimize the coagulation. Also, the surgeons requires this. If the patients had a cognitive impairment, you must be convinced that probably the rate of postoperative delirium is higher. Anesthesia, so far there's no difference between randomized controlled trials, but I think based on the retrospective data, we can be convinced that spinal anesthesia is the preferred technique. The intraoperative management, we should look for stability, we should avoid hypotension. If we use drugs. We should use short-acting drugs when we do a general, and we have a block. We use usually the continuous infusion of remifentanil, and it doesn't matter at the end if you stop remifentanil because you have a well-working block. So that what you can see without block, hyperanaesthesia after you stop remifentanil, you will not see. You should, for all these blocks, we give tranexamic acid for increasing the coagulation, and we should avoid anticholinergics because of the high delirium rate, and post-operative multimodal concept with peripheral nerve blocks. And I think that's it. Thank you very much. So everybody's looking on my watch. So you see here, you palpate first the anterior superior iliac spine. Then you place the probe transversally on the patient. I show you first. And then you advance the probe parallel downwards and until you see the anterior inferior iliac spine, and then you move the medial end of the probe caudally in this way. So this I show you now. This is the movement that you will see now. Now we can change on the screen on the solo picture. Yes. Okay, we'll try it over here. So again, this is medial, left side is medial, right side is lateral. This here is the anterior superior iliac spine, this here is the iliac bone. Now I move the probe caudally. And now I see here the inferior anterior iliac spine, and now I move my medial probe. I move my medial probe, the medial end of the probe. I move now caudally, and you see now here the iliac bone. This is the iliopubic eminence. You see here on the medial side the pulsation of the femoral artery. Here, lateral from the femoral artery, you see the femoral nerve. This all here is the iliopsoas muscle, and your target is this white area, this white hyperechoic area. This is the tendon of the iliopsoas. And when you have this picture, you advance your needle from over there, from lateral, the needle tip until you have bony contact here, and then you start with your injection. And an effective block is when you see that the tendon of the iliopsoas is lifted up. This is the pen block. In my eyes, an easy block. You have a classical, you have clear anatomical structures, and it's a block. If I go a little bit more distally, you see here now coming, this is now coming the hip. Yes. This is the hip joint here. If I go more cranial over here. Usually you have no motor weakness when you do this block, but you can imagine if you inject 20 or a little bit more local anesthetics. Secondarily, the local anesthetics can also block here the femoral nerve block, though sometimes you see in the patient, yes, okay. Sometimes you can see in patients quadriceps weakness, but this is not mainly because you have, or this is only the result if the local anesthetics here that you have injected has also blocked a little bit the femoral nerve. But usually you will not see any motor weakness. So again, you start over the anterior superior iliac spine, you go down, you see here the anterior inferior iliac spine, you turn the probe medially, and then you have here these structures, and then you advance your needle from cranially, caudally, until you are with the needle. So you are coming with the needle from here to here, and then you inject. Okay, that's the pen block. Now I show you the iPad block. Please stay there.
So for the iPad block, for example, the knee should be, the leg should be outer rotated a little bit and flexed in the knee. First of all, we can go to the surface. We can change again. I see. Show the other one. Maybe we can, yeah, yes, it's much more better to demonstrate. So, the leg is outer rotated, flexed in the knee. You take again, it is for the pen, a convex probe, and you place the probe for the first block. The medial approach is like this one, and then you advance the needle from here. But I prefer the other one. I place the probe in the popliteal crease like this one, and then I move the probe. I show you there are two options, a distal option like this one, or a more proximal option like this one. This is the proximal and this is the distal option. The distal version is at the level of the condyle and the more proximal one is at the level of the femur. Okay, so now we move to the ultrasound image. So I place the probe now here at the level of the condyle. So, this is medial, this is lateral. These are the medial, this is the medial condyle, this is the lateral condyle. If I move the probe now cranially, you can see the condyles disappear and you can see only one white line, and this here represents the femur. And you can see also, if you do the block more distal at the level of the condyle, you have a faster onset of block, but probably you are too close to the capsule of the knee. And there are some publications showing that you have, when you do this block, you have injected, you have done an intra-articular injection. And the surgeons are not so happy with this. So I would recommend probably this is probably a safer, can be reduced again a little bit. It's too, I think it's too dark. Okay, now you can see here, this is the distal femur, medial, lateral, and this are the popliteal vessels, and maybe here or here, these are the femoral, the tibial and the peroneal nerve. The needle is always advanced from medial, never from lateral, because then you are very close here to the peroneal nerve. And the needle is advanced close to the femur shaft over here, parallel to the femur shaft, until the needle tip is over here. And when the tip is over here, under retraction, you slowly retract your needle, and under retraction, you inject your local anesthetics over here, 20 milliliter of local anesthetics, and then you will infiltrate the popliteal plexus, which is located over here. So this is the posterior approach. The anterior approach is, as you can see here, you can see here, this is medial, is maybe now anterior is here, posterior is over here. This here is the femur. You advance your needle now from here to here. Again, here you place the end of the needle, and then when you retract your needle, you inject your local anesthetics over here. But I like the other one, is nicer, but there is no difference in the outcome or in the success rate and so on. But I think more of my colleagues, or this is what my impression is, that more of the colleagues are now doing the popliteal. You can see here again, if you advance your needle here and then tip over here, then you retract. It's also very safe. Here, this here, probably here are the tibial and peroneal nerve.
Okay. And again, if you have injected a huge amount of local anesthetics over here, you can find in some patients also weakness of the foot as a blockade of the tibial and the peroneal nerve. And that was what I should demonstrate. Now what you want me to demonstrate, you can choose any block you want.
Can you demonstrate the adductor canal and the vastus?
The adductor canal and
The
vastus medialis, yes. I need a convex, but a linear probe. Okay. So, first of all, the skin, yes. We place the probe maybe over here. If you are not, you should looking for the femoral artery. If you don't find the femoral artery, you start in the crease level. There you see the artery always, and then you scan down until you see the femoral artery. And I show you now maybe the adductor canal block starts here. Then usually the adductor canal block has a length of between 10 to 15 centimeters. It means from here to here. Here you can do an adductor canal block. A femoral triangle block is when you do the block a little bit more proximal here, and you can do the adductor canal block at the whole length of the adductor canal. But there are also some people advocate a distal adductor canal block. This is where the femoral artery dives into the depth on the backside and becomes the popliteal artery. If you do a distal adductor canal block and you inject 20 ml of local anesthetics, the local anesthetics can follow the vessels, the femoral artery, and then you can also partially use a sciatic nerve block or a block of the popliteal plexus. This is published, and it means distal adductor canal block. Maybe you have done 2 blocks. Okay, now we move again. So, first of all, you see here, this is medial. No, this is medial on the left side, and this is lateral. This here is the sartorius muscle, and this is the femoral artery. Another names for the adductor canal are mid-femoral block, mid-sartorial block, and so on and so on. But only with ultrasound you can define the beginning of the adductor canal. And therefore you have to move the probe a little bit more medially. And if you are, now for example, I'm very proximal, and you can see here, this is the medial end of the sartorius muscle, and you see a big muscle over here. This is the adductor longus muscle. Now I move the probe caudally, and you can see the big muscle, the adductor magnus muscle disappears. If I go more proximally, you see here the big adductor longus muscle, and this is the sartorius muscle. Again, you see how the adductor longus muscle changed his size. And the beginning of the adductor canal is exactly there, where the medial end of the sartorius muscle and the medial end of the adductor longus muscle intersects. It means here. Here they are at the same level, and here starts the adductor canal. If I go proximally, here I would have done a femoral triangle block, and from here I do an adductor canal block, adductor canal block, adductor canal block, and here is, you see here, the femoral artery disappears, and here ends the adductor canal. So, if I have found my adductor canal over here, then I move the probe laterally, and always lateral from the artery. This here, this will be the saphenous nerve. and you advance your needle. You can do it out of plane, you can do it in plane. You advance your needle over here, and then you inject. And by injecting local anesthetics, that means the area here becomes hypo or anechoic dark, and then you see a very good discrimination of the saphenous nerve over here. So now the nerve to the vastus medialis, you go more proximally, and probably this here, this would be the nerve to the vastus medialis. But I would always recommend, if you want to do the adductor canal block and you want to block the, in addition the nerve to vastus medialis, use the nerve stimulator, which gives you more information. And when you close, when you advance your needle close to this structure here, then you turn on your nerve stimulator, then you see contractions of the vastus medialis, then you know that this formation will be the nerve to vastus medialis. So now I'm proximally, and if I go more distally, this here will be, this runs later on in the vastus medialis muscle, and more distally you can see here the saphenous nerve, and we have done an adductor canal block over here. The next block. Finished. Finished.
So are there any other blocks that you would like to learn from Professor? So if that's all, maybe we can move on to the Q&A session.
Okay.
Yes. Are there any questions from the floor?
I think it's not, yes. Thank you.